Kind sir. Thank you to Bosch & Lomb for giving me this opportunity. For those who know me and those who don't, I live, breathe technology. I would have been a physicist if I was not a surgeon. I can rip open a machine and put it back together, not because I'm a good surgeon. I'm a good surgeon because I understand machines. That's what the difference is. So, okay. Now, as we are talking, I'd just like to add what Dr. Srilakshmi said. Amazing presentation, very, very lucid. The reason why would you, when you're operating a high myope, the caveat is, if you're using an EDOF, go for a little bit more myopia. I've got huge number of lenses, 400 plus 500. BNL probably knows, probably highest, probably in Asia. We've done in the last couple of months, nearly crossed 500 by now. And my experience tells me when you're working in high myope, leave it 0.75 myopia. The reason, these people have larger pupils. So smaller pupil, like one patient you were showing had a small pupil, and I was mentioning Dr. Mohan Rajan, this patient will be overcorrected for near and overcorrected for distance and have a beautiful near vision. So EDOF lenses are sensitive to a pupil size, but not as sensitive than the multifocals. But if there is anything you need to understand about EDOF lenses is your pupil size, your anterior chamber depth, and your corneal surface. If these three things are in order, but of course the macula, then everything will be fine. So presbyopia, I call cataract surgery in iatrogenic presbyopia. You're probably making the patient more presbyopic than he was probably. And what is the solution? We are looking for the Holy Grail. Holy Grail is, you know, the Grail where the blood of Christ was supposed to be there. People are looking for it. Still not there. Is EDOF the answer? That we will see. I have no financial disclosures for this particular topic. Is EDOF the broken link which is going to join the monovision, the bifocals and the trifocals? I was one of the very high users, like Dr. Srilakshmi, of trifocals and bifocals. I feel bifocals are over, practically finished, and monofocals are going to die a slow death as the EDOF technology improves. So I'll be comparing two talks. Dr. Piyush, my friend, is not coming, so I just sat there and made his presentation also. So I'll be talking about spherical aberrations. If you understand spherical aberration, you'll understand the EDOF technology better. Then we'll understand about the different types of EDOFs. Then we'll talk about the pupil size, how it plays with the EDOFs, how do corneal surface disorders affect it, and your patient selection and pupil decentration. So categorically, presbyopic IOLs are in 4 types. I don't need to tell all of you. These are different categories of IOLs. Luckily for me, Dr. Srilakshmi did touch a lot of them, so I will just breeze through them. Mechanism of working are either you have a diffraction, either you have a refraction, or you have a pinhole effect, or a true accommodation like crystal lens. So the principles are the monofocal has a single point focus. The multifocals or the trifocal or the bifocal have 2 or 3 discrete focus intervening with a zone of blur. We will see a diagram there. And this zone of blur is the biggest problem, because this is the point where the patient starts losing light. There is a light loss. This is the area of blur. Now this is how it happens. In a monofocal, you'll have a single point source of light, crystal clear vision, but yes, the moment you move away from that focal point, it's gone. In a bifocal, you'll have 2 points of focus, but the intervening zone between these two is a zone of blur. These patients will have, if they have a large pupil size or if they are prone to glare and halos. In a trifocal, you will have 3 of them. How does an EDOF work? EDOF has a single point of focus, but it's elongated over a point. And that is done by playing with the spherical aberrations, creating some diffractive zones or some patented refractive zones in the center to give you this continuous zone. So the advantage is there is no light loss. You're just bending the light. You're just bending the light over a longer period. So this sometimes can only probably give you a little bit of waxy vision on the out edges of the object, but by far and large, most of the patients are very, very happy with this. So let us understand the spherical aberrations first. We all know what is a positive spherical aberration. In a positive spherical aberration, the peripheral part of the rays are meeting before the focal point. In the negative spherical aberration, they are behind. The EDOF lenses, the real pure EDOF lenses work on the negative spherical aberration. They play on the interior surface of the lens, make it more prolate in the center, cause more bending of light, so you have a stretched zone of focus. Now the next question would be, if this was so simple, why weren't we doing it earlier? Why not increase the negative spherical aberration and give 3 diopters of AG? Why just stop at 1.52 or 1.75? The reason is when you play with the negative spherical aberration, there is a very, very small zone you can play around with. We'll understand why. Because if you increase the negative spherical aberration, your peripheral vision starts going for a 6er. This is what can happen. So this is the normal aspheric oil. We were talking about aspheric IOLs. The positive spherical IOLs and the negative. In the negative, you see there is a zone of confluence, the dark part. That gives you a tunnel straight beam of continuous vision. So enhanced monofocal lenses work on this technology, and the diffractive monofocals like the Vivity or the Synergy or the Panoptics, they use a combination of spherical aberration and diffraction. So the diffraction compensates for the other part, so that's why you can probably have a defocus curve of 3 diopters there without compensating the peripheral vision. So this is what can happen if you increase the negative spherical aberration. The peripheral image will go for a 6er. So there is a fixed amount you can play if you only want to play with the spherical aberrations. So the asphericity, this is what I've tried to show the audience is if you take the photograph through a fisheye lens, it's highly spherically aberrated. This is what can happen. The peripheral will get distorted. Now, this is just for a reference point. Now, look at when I talk about 0.2 logmor, it's 6/9.5 vision. Now, the definition of EDOF by the American National Standards Institute is any IOL which gives you N9 vision with a distance vision of 6/7.5 with correction. In 50% of the cases, it should be an EDOF lens. It's a very open-ended definition, which means if the patient is seeing 6/7.5 with or without glasses, and with the same glass he can read N9, in 50% of the patients, it's an EDOF lens. So that can happen with different kind of pupil sizes also. So it's a little loose definition, but I'm sure they're working on it. So if you see an EDOF lens, this is what you'll see across a zone till you reach 1.5 diopters of near AG. But if it was a monofocal lens, at 0.75, you'll start getting the fuzz or the shadow effect. So this is how an EDOF lens will increase your depth. Now, understanding types of EDOF lenses, this is a huge list. Now, Physiol, Isopair, they'll give you, so the Bausch & Lomb, J&J, Technis gives you supposedly 1.5. The marketing material says 1.5, but if you actually do an optical bench study and see, it is 1 diopter and the total zone of 2 millimeter. So it's actually a near depth of 1 diopters, but the company markets it as 1.5. But if you actually see the Bausch & Lomb LuxSmart, it goes to 1.75. Now, once you play with this lens and your cylinders and your blending vision, you'll see what magic you can create. Now, this is a category of hybrid lenses, hybrid refractive, hybrid diffractive, pure enhanced monofocals. I will not go into the principles. Dr. Srilakshmi's already talked about them. I have used most of these lenses. I've moved on, slowly used them and experienced them and had my fun with them and moved on. Symphony. Now, what are the issues? Why do these lenses never pick up? Why do these lenses never pick up like a rage? The reason is this. Sometimes you'll have a blurred vision, near vision, halos, glares, ghost images. Now, this is what a polyfocality will do. Rings will do to you. Now, these are non-specific. It's like Pandora's box. Any patient can get a bad result. With the best of surgery, you'll have an unhappy patient. So let's understand the photic phenomenon. You could have a point source of light. This is how a glare would look. This is how a halo would look. And that's how a starburst would look. This next 3 slides will help you catch issues in your patients. Now, patient, when he says he has halos, you have to ask him, do you see rings of distinct circle or a lens flare around the light object? If that is so, that's surely your multifocal diffractive lens. Just keep your eyes closed, that's what is causing it. Now, if the patient is talking about a glare, this could be a PCO bang in the center. A PCO is also known to cause a lens flare. We'll see how it looks. Now, this is what a starburst sign would. Starburst sign is classically seen in post-LASIK patients due to the interstitial haze in the initial part. Dr. Mohanraj and all those people who do LASIK surgery understand what I'm saying, and it tends to go away. But it can also be happening in PCO or polar cataracts. So if you have a central PCO, you could be having... Now, lens flare classically is due to an uncorrected astigmatism or astigmatism induced by the surgeon. You may have caused some astigmatism. So whenever a patient is complaining of a lens flare and he's saying, "Mere ko light stretch dikhta hai," please do a tracy if you have one, or do a refraction, and you will find these patients have some uncorrected astigmatism. So the pinhole effect, again, I'm not going to talk about. Now let us talk about small aperture, gone, finish. I've used a lot of visual lenses also. I used them in huge numbers, but then I slowly moved away because they were not up to the mark. They were not giving me the results even with blended vision. Beam shaping technology, VVT, I was just discussing with Dr. Mohan Rajan. We've used a lot of VVTs, but over time I've kind of moved on. It works on a central rays principle of 2.2 millimeter, where there's an X-wave technology, and this is an added refractive zone in the center of 2.2 millimeter. It's very visible even on the slit lamp. Issue with these lenses can be very, very pupil size dependent. And if this lens decenters, it can cause high order aberrations. I have put this in some very VIP patients. I'm in Delhi, so you know there are all politician base are majorly in Delhi. I did put it in some top VIP politicians, and then I had burnt my hands, and then whatever is the story. So after that, I became slow. Now I look for pupil size. If somebody asks for a VVT, I look for the pupil size. Lucidus, again, I've used now. VVT, we've already talked about. VVT will give you a 1 diopter correction. VVT, I'm talking about Eyehance, will give you near 1 hand, but Eyehance is a beautiful lens to be used if you want close your eyes, and you can use this lens. Play with micro monovision, it will do the job. What actually decides the actual quality of the lens is the modular transfer function. For all the people, again, who have tracy, they can measure the MTF of the lens on the machine. A trifocal lens will have a peak, a dip, a peak, and a dip. So these dips are the ones which are caused by the zone of blur. This is where the light is lost. So the patient may have loss of contrast at night. A bifocal will have 2 peaks, monofocal will have single peak, but look at EDOF. It has a single peak and it slowly eases out. So there is no loss of contrast. As the object comes nearer, it just blends in. So you have a clear continuous zone, and slowly it fades into it. Again, this describes the whole thing. I will not go into the details. Now, this is how the lens is. The company says 2 diopters, but I think in my practical hands, 1.75 diopters. So the trick I do is, if I'm planning 2 eyes, I do the non-dominant eye first, overcorrected by the first myopia as long as it's on my biometer less than 0.55. So I hope you're getting what I'm saying. So I'm doing my IOL master, and my IOL master says minus 0.45 or minus 0.42. I use that lens for the non-dominant eye. And based on the response, I usually plan the second eye after 5 or 6 days. I want the ELP to settle down. Then I plan the second eye. It gives me a lot of playing range. So this is a trick I'm sharing. That's how we can get, and Dr. Sri Lakshmi was talking about, that's how you can get 80 to 90% patients 6/6 and 6. Because with both eyes open, they're doing fantastic. So if you're operating the non-dominant eye, and I'm sure you have so many times realized, patient is even 6/12 in the non-dominating eye, and in the other eye is 6/6, he has no complaints. He's absolutely singing songs. So initially beginners, if you plan to do the non-dominant eye first. When I do clear lens extraction, I plan the non-dominant eye first. I go for the first myopia as long as it's less than 0.5. Correct that, wait for 4 or 5 days. As long as the patient is little myopic, even if it's 6/9 parts, I'm superbly happy. Because the moment I correct the second eye, he's going to be N6, N5, and 6/6, both eyes open. And this is what the patient actually wants. So the lens is actually based on a very patented transition zone. It's called Optics Pro technology. The first order, second order, third order, and fourth order. The first and the third order are for near vision, and the second and fourth order are used for intermediate and distance vision. Now, again, I will not get into this, jump this, because I'll just skip the video. I'm just trying to show that I was doing a session a little while ago on astigmatism. So I am very, very, very intolerant of astigmatism. So a lot of times you're told that 0.75 astigmatism you should love to live with. But if you plan to give the patient the kind of vision he wants, attack the astigmatism whenever you can. So in case you can, I usually do OCCIs if the astigmatism is less than 0.75, or I shift the patient to a femto and reduce the astigmatism. On my machine, I can take it down to max 1.5. I can't correct beyond that. Otherwise, then it shifts to toric. So once I've done that, I put the lens in. This is an OCCI. I'm just showing you that. This is I've made another opposite incision, and to correct the 0.75 astigmatism. So advantages of this lens are, it's a 4-point lens, it's very stable. It will not rotate, it will resist decentration. So remember I said, if your EDOF lens, because it is aberrated, if it decenters, it will cause high order aberrations. So instead of 2 points, this has 4 points. So resist decentration. The material is rock solid, it is very rigid, it resists decentration. It's totally glistening free. So you do not have these glistenings which you may see with other IOLs in this, and thus the quality of vision is going to be superb. It can be inserted through 2.2, so it's actually a refractive surgery. You're not inducing any astigmatism in these patients. There was a study done to compare the depth MTF curve of Vivity versus LuxSmart, and you can see that LuxSmart, the one in yellow, scores far more area under the MTF curve and gives you a better vision. For people who want to understand what the MTF curve in real life can do, I think I could not have found a better picture to explain to you. A higher MTF curve, you will be able to see till max the spatial frequency of this contrast loss. If the IOL has a higher area under the MTF curve, your ability to differentiate the finer lines to the highest point will be higher. So your ability to differentiate the contrast is going to be superb. So look for an IOL with a high MTF curve. Now this is a photograph with a lower MTF curve and a higher MTF curve. Now if the light was reduced in the first photograph, you will start losing the edges or the flare. If the lens decenters, and if it's a high order aberrated lens, if the lens decenters, it can cause problems. But the best part about this lens is it's a 4-point touch system. There are no zones which are separately visible. So the decentration will not affect the visual quality as much as the other ringed IOLs or IOLs with visible optical zones. So I hope I'm making it clear. If there's no visible optical zone, the decentration will not be that bad. So we've done 400 plus lenses, and this is the questionnaire which we talk to the patient. One thing is, please look at the height of the patient also. I get a lot of surprise look when I talk about that. I introduced this concept 2 years ago, 3 years ago. A taller patient is going to be more tolerant to your EDOF lenses. Even if you use a simple eye hands, patient will be more tolerant because of the height, the arc length of reading is higher. I'm nearly 6'2", and I'm 55 plus, and I don't need glasses. It's not that I don't have presbyopic correction, but my reading length, because of my arc length angle, is higher. But same person my age, probably shorter height, would need glasses. So taller patients, you can actually play around, get away very easily. Who are the patients to watch out for? Patients with small pupil, patients with surface disorder, short height patients, patients who are allergic to reading in the low light, and small pupils. These patients, you plan your EDOFs well. Always do the non-dominant eye first. This is a lesson I've learned over so many years, and all the things I'm sharing are practical, real type things. If you ask the patient that, are you okay seeing some halos but have good vision? Tick trifocal. And if you don't want halos, but you're okay with intermediate vision, 80% of your daily life you will not require glasses, tick EDOF. Guess what? All of them tick EDOF. You need to educate the patient. If the patient walks in thinking, "Bhai, aapne to mere ko bola tha, paas ka chashma lagega nahi," wrong. Leave the choice to patient. Bole, okay, near glasses you want independence, fine, but there may be some photic phenomenon. Or go for EDOF, no photic phenomenon, but you may require some glasses in low light or stuff. All of them will go for EDOF. And this is an informed consent. So this is what works in my practice. So what are the things which actually work? Q value, keratometry, and astigmatism. If the astigmatism is very high, don't think of EDOF. Dry eye, don't think of EDOF till you've treated the dry eye. Keratometry, very steep keratometry. In my practice and my hands, I think EDOFs don't perform that well. 47, 48 keratometry, there is something wrong with the ELP and the anterior chamber depth. There's an issue. So biometry formula, make sure the biometry is superb. If you have a very shallow anterior chamber, then also you may have some issues, 2.3, 2.4 millimeter anterior chamber in high hypermetropes. Pupil issues. If the pupil is very small, the lens will form perfect for near vision, but it will be not that good for distance. So plan under correction in smaller pupils. In large pupil, you can probably get away with large overcorrection also. IOL centration, tilt, refraction, and surgeon-induced astigmatism, patient expectation and counseling. If you worked on all these, you will have these advantages. The advantages of EDOF: more forgiving, less problems with glaucoma, more tolerant for ERM, no glares and halo, excellent night vision. So this is our study, similar like yours. 78% of our patients are 6/6 and 6 both eyes open. Your study said 80%, mine is 78%. And this is in nearly 108 patients. We've not done for all 400 patients we've done. 108 patients, study of 2 months. So my belief in this is moved up. I'm even operating my super VIP patients with that. I'm planning to operate my brother-in-law for the same lens for a clear lens extraction. So as I said, 78% are in the target zone. Patient selection criteria I have mentioned just for repetition. Pupil size, again, very important. Look at the pupil size. Very shallow chambers, Fuchs dystrophy, small pupils in deep anterior chambers, other diseases, asteroid halosis. I don't use it in uveitis patients, retinal detachments. Moderate myopia you have to watch out for. Moderate myopia patients are very difficult to make happy, because they are used to a very good, decent near vision. So you need to counsel them well. Fuchs endothelial, we closed. I think that's it, sir. Thank you. And toric EDOF, toric LuxSmart is going to be available very soon.
Friends, I think we should confess that it cannot be a better presentation than what Kamal beautifully explained, the IOL technology, how the EDOF lenses work, and also his experience with the LuxSmart lenses. But I want to ask you some questions. RC, you have any questions for Kamal? Yeah, okay. I want to know, because in high myopes, I tend to use, of course, explaining the situation to the patient, because these are all patients who are used to very good near vision in their life. I'm talking about very high myopes. Those patients, I tend to go in for a trifocal. Sometimes I've used even a Technis +4 lens in one eye and +3.25 in the other eye, because if they don't mind some decrease in the distant vision, but the near vision has to be very good. That's one thing. Second thing is, what Kamal has rightly said is, you need to sit down and do a math in the patient. Do a math and find out what exactly the visual requirements is. And depending on the visual requirements, suppose they want to go play golf or driving, those are the patients you need to push them on the EDOF side.
Yeah.
Okay? Or if they're just sitting at home watching a TV serial and reading a book, those patients you put them on the trifocal side. So I think this is a broad classification, I would say. Of course, you need to go into the nuances of these things and find out if they are really bothered out, whether they're the type A personality asking too many questions. Then those are patients who are likely to complain of glare and other things. So how do you decide on number one? But what I have found out in my practice is that the new middle, what is the new middle? Can anybody tell me what is the new middle? The new middle is the near point has receded from 35 centimeters
to 40-45
to 45-50 centimeters.
Absolutely.
You see how many of you are using the cell phone nobody is using at 35 centimeters. Nobody is reading a paper nowadays at 35 centimeters, because everybody is reading papers, newspapers on the iPad, a tab, which is about 50 to 60 centimeters. Okay? If you see the Hindu paper sales and the Times of India sales in Chennai, it has gone from 3.5 lakhs to 2 lakhs in the past 10 years. Why? Because people are now embracing digital technology for reading papers also. So if you're using the cell phone, it is here. If you're reading an iPad or doing a tab, it's here. It's no more here, 35 centimeters. Unless otherwise you're having housewives, house husbands, and of course mother-in-laws, those patients, you put them in the, because they are all staying at home and they probably read papers at 30-35 centimeters. In this way, I think the market for EDOF lenses is going to become very huge.
Absolutely.
The simple reason is, as I told you in the beginning, because in trifocal lenses, the problem is the halos and glare and the photic phenomenon. That will vary from one patient to another. You cannot predict. You tell the patient, okay, you will not have 100 patients, out of 100 patients, 3 or 4 will have glare, over a period of time will become all right. Some of them, they don't become all right because neural adaptation doesn't take place. There's something which, there's no technology by which you can find out pre-operatively whether this patient will go in for glare halos, whether glare persists or not. So in that case, The patient is, how do you select the patients, Kamal? And Sri Lakshmi also.
So as I said, sir, first of all, Dr. Sri Lakshmi, I think, was reading my thoughts. My example to the patient is like, it's like selecting a car. If I give you, like, don't go by what I'm trying to say, or don't get tied down to it. Mercedes represents opulence, interiors, luxury. BMW gives you that grunt, that torque. For people who understand, the torque in a car is different than the BHP, brake horsepower. Torque is the raw acceleration which you get, and RPM is how fast you get that into that zone of RPM. And Audi is a mix of both. Audi gives you best of both worlds. So I tell the patient, this is an Audi. It gives you a trifocal, it gives you a monofocal, and the best of both worlds. So, and another trick I'm sharing with you is, I never tell the patient to use a particular lens. I say, okay, these are my favorite lenses. I never say these are the best, because that is contestable. That is actually contestable. There's no best actor also. That is contestable. So I use the word saying, these are my favorite lenses, and I would say, this is the premium in that category, and this is an affordable in that category. I don't say this is cheap, because when you say cheap or economical is a bad connotation, but affordable is a very pleasant word for good quality and yet affordable. So that's how my counselors are trained, and that's how we are able to run the kind of numbers we run. And there are some other EDOF I was talking about, I won't talk about them here. That's how we hit those numbers there also in a period of months, because you tell the patient rightly and never push him towards one thing. Then the patient might start thinking that, you're pushing towards one particular brand. And selecting of the patient is, in a multifocal or a trifocal, a very fastidious patient, I would stay away. Because I don't know whether he's that 4 or 5% of patient who's going to have photic phenomenon. And then he's going to eat your head off. Yes. I would push this patient towards a blended vision EDOF. Number one. Number two, case selection, as I said, very small pupil patients, I always undercorrect them. The first undercorrection on my 0. Again, how I select my cases, because these patients will have a myopic shift. Another one, especially for people who are not doing a lot of EDOFs, don't be fooled by your AR. Your AR is always going to be myopic. You shoot, the patient is 6'6", you shoot, it's minus 1.25, minus 1.5, minus 0.75, minus 1. Don't be fooled by it. That's the AR measuring through the central zone. That's supposed to be there. The central zone is at least minus 1. So don't be fooled by that. And if your optometrist puts minus 1, the patient will strain, accommodate, and still see through, and he'll be prescribed. But if he wears that, his vision for distance is gone. So never correct the low myopia on your EDOFs. That's again a trick I'm sharing with you. Leave it. That's what gives him the depth. So the pupil size. The surface disorders, if it's a chronic surface disorder, I stay away both from a diffractive lens and an EDOF. Then I go for micromonovision. Then I plan a micromonovision in such a situation. I operated my wife recently. She has a dry eye. I didn't use any one of them, and I put a micromonovision lens, both eyes. She's very happy. I knew, number one, my wife. So I wanted to stay happy. I said, if I put it in dry eye, I wanted to put LuxSmart. If there was any issue because of the surface disorder, there'll be trouble. And I said the height of the patient, the profession and lifestyle of the patient. If he's a patient, as Dr. Mohan beautifully said, if he's a patient who likes to read a lot, read books, okay, you can go towards trifocals also. But majority of the patients are working at the intermediate. All of us are working at intermediate. Our mobile phones, and guess another plus point, in all your digital gadgets, all you need to do is increase the font by 10%, you're still able to read. So that's what we do. A lot of patients who are short-heighted patients and they've got a need of, say, Doctor Sahab, mobile mein dikkat hota hai. I just tell my optom to increase the font size slightly. I say, wow, wonderful. Because most of the reading is in a mobile phone now. And now you have foldable mobile phones. So you should know how, in your practice, and your team should know how to play around. And then you have more happy patients. So the next patient will just come and he will not say what he wants. He'll say, just put what you put in Mr. Malhotra. Because my friend on morning walk is very happy. So then you look up the records, or sometimes he'll say, koi smart lens dala, Doctor Sahab, aapne bahut smart lens hai wo. So that's how your practice grows. So be smart. To use technology, I always tell people, a smartphone is as smart as the user who uses it. You don't know amount of stuff you can do, amount of stuff I can do on my phone is crazy. I can do graphics, I do animations, I do everything on my phone. So to be able to use a smart technology, you need to be smart first. You need to understand what you want and what the thing can give you. And then you can get maximum out of it. So similarly is with this particular lens. You just understand the optics and you get your hands on it, and slowly you'll realize the lens becomes a slave in your hand. Like a machine. Once you understand a machine, it'll play it through the way you want.
I think you hit the nail on the head. I think it's very important for people who want to use EDOF lenses. You want to give the best to the patients as far as the range of vision is concerned, the contrast, quality of vision is concerned. I think blindly we can go in for the LexSmart technology.
Yeah.
The simply not because it's a Bausch & Lomb session I'm telling this. I'm just telling you because LexSmart is a fantastic lens. It's a beautiful lens, lovely injector, and it's a 4-point haptic. We have seen the experience. I think I implanted one of the highest number of Acryos Evo in the entire country, and more than 3,000, 4,000, 5,000 lenses and all we have implanted. And we have not had a single case of decentration of the Acryos Evo lenses because of 4-point fixation. Even if there is a capsular contraction, it doesn't decenter. So I think the biggest advantage is the 4-point fixation, and it's a hydrophobic lens. And the Acryos Evo, at least it was hydrophilic, so the ag cap rates were a little high. Here I think it's very good. I think the chair time has become less because of EDOF lenses. Otherwise, in the multifocal, you need to convince them, talk to them, back and forth, you have to tell them. That consumes a lot of your time, and ultimately you're not sure of your result. Also, here you can consistently hit the bullseye and make the patients happy.
The best
and
part
one
is
happy patient will bring you over another 100 happy patients. But one multifocal patient will sit in the OP and spoil your OP. Make sure the other people don't come there and create a big... and I'm talking about a trifocal patient who's unhappy. Because there are more chances. I'm not telling they're all trifocals. There are indications. Yeah.
I have a question for you.
Yes, no problem.
Which EDOF lens you prefer in post-refractive surgery patients?
I've done VVT, I've done LexSmart also.
I've done VVTs. Now my current favorite is LexSmart/iHands. I've stopped using VVT in post-refractive. Especially if the cornea flattening is less than 39, I don't touch that particular cornea with a central different raised optical zone.
What about the spherical aberrations, the pre-existing in post-LASIK patients?
That's
well,
exactly.
Hyperopic LASIK. Probably the hyperopic LASIK.
Hyperopic LASIK is a different
No, I'm talking about myopic
It's a
LASIK.
totally
We have
different
done
ballgame.
this LexSmart, I've done Lucidis also, I've done VVT also.
Sir, I also implanted, but
Yeah.
I was wondering...
Sir, on a lighter note,
No, the biggest problem we had in post-LASIK was the optical biometry. But now with the Barrett's formula and other things, you're able to get it right on target. And if you're able to get it right on target, then it's this thing why we should not use EDOF lenses. Any of these EDOF lenses are good for the matter.
So on a lighter note, when I was doing multifocals, a lot of multifocals, I was a very high volume user of multifocal. I had absolutely saved as a favorite one article on neuroplasticity because I had to sit and counsel the patient that there is a concept on neuroplasticity, it will take a few months for your eyes to get result. So I'd saved that as a favorite on my phone. So whenever a patient would say this, I would open that page and show it to him. Please go through this. I give you a link, go through that. You had to learn psychiatry to talk to patients of diffractive lenses. Unhappy patients are very difficult to handle.
Yeah, sometimes I tell the patient if they have halos, I say, excellent sir. That's the reason. Your multifocal lenses are working very well for you. So you have to motivate the patient because these glare and halos is something, you tell them, very good, it's working very well for you because after some time maybe he may forget about the halos or maybe disappear also after a few months. And these trifocal lenses are really fantastic in that way. But you need to know where exactly you want your patient to be. That's important. I think you need to do a good preoperative counseling, know the nature of your patient, what is the nature of the activities he's doing, and then you need to ask, I told you, whether he's going for high and occasional readers, because many of the patients say, no, I don't mind occasional readers. Yeah. +1, I don't mind. So, because I want good quality vision, I want to play golf, I want to drive, I'm very active. Because most of the patients are coming, they're not 70, 80 plus nowadays. That's a changing cataract scenario. They're all coming with 6'9", 6'6", because they're not able to drive at night. So these are or not able to, because of the decrease in the quality of vision. Amit, anything you want to say?
Eyes closed.
For me, if you want to, if I would prefer EDOF lenses or a high-ans, for that matter, not a trifocal. High-ans is fantastic.
See, IONs is more towards a mono. So I think maybe because it's a mental block we have, I think just wait another few years. The new mono is enhanced monofocal, or think like non-blended zones. That is the future. That is the future.
I want to eliminate monofocals in my practice, either multi or EDOF. That's it. To offer them, some no glasses. The best
That's why her hospital is called Win Vision. She wants to do only multi or... Asi, any comments from you, Asi?
Actually, in our practice, what we do, so when they say that, these questions of EDOF or multifocality or presbyopic lenses, we see in most of the occasions you don't need any glass. And honestly speaking, Dr. Mohan Rajan gave the importance. He uttered one word, most of the patients forget. Because this is a serious incidence in the patient life that had gone through the cataract surgery, went through so many counselings, expectation has gone up, down, so many complications. In their terms, it came from itchy eyes to watering, redness, whatever. But honestly speaking, after quite some time, everything settled down, so it passed off.
Yeah. Anything you want to add? I think, some questions from the audience we can take. How many of you are using LuxSmart lenses here? I think we took the question in the beginning, no? LuxSmart. We are
going to use it.
Going to use it after this session. Bausch & Lomb people are there, they'll give a 50% discount on them.
See, the kind of marketing from J&J.
Or they may give even 10 lenses free of cost.
Probably
for those who attend this
I
session.
think Bausch & Lomb people should do this.
Yeah, please.
In the one eye, monofocal, can you use a EDOF in another eye?
Why not?
And one
We
eye
have
is
done that.
Okay.
We have done that.
Okay. And
We have
one eye
done-
multifocal and another eye EDOF.
That also I have done.
I have not done.
That I have done. One patient recently operated, is an ophthalmologist. She is very, this is about 3-4 months since, or even more than that, since she had a panoptics lens in one eye. Then other eye I put, she was very concerned about her halos. Then other eye I put VVT. She's quite happy. Quite happy now. Yeah.
I can share one experience.
Yeah.
One patient, I won't name the trade name, etc. So I had some presbyopic IOL, and the complaint was as such, it was going to be explanted or exchanged. The other eye had the cataract. So we did the cataract surgery with a monofocal IOL, and you won't believe, after the surgery, the patient said, I don't have any problem in both the eyes, and this is being settled. This is the real life experience. Yeah.
I think so. I think we should coax the patient to have the other eye surgery, not as Kamal said, I would wait for a few days. Because you can titrate, you know exactly where you stand in the first eye. I don't do dominant or non-dominant. First eye, I aim for hemetropia. The second eye, I aim for -0.5. If it's a high-ans lens or something like that. So, I don't believe in this dominant or... Okay, only my wife is dominant on me. That's a problem.
One point I'd just like to add is 32% of my practice of EDOF is the patients where I've done one monofocal earlier now. They're coming back to me after 2, 3, 4 years, and I'm doing EDOFs in these eyes. They are very happy.
Sir, you were talking about decentration again and again. How much decentration is there exactly?
37% of IOLs will decenter by 0.8 millimeter. The moment you cross 0.6 millimeter, that's when things start playing up.
With because I'm doing a lot of flags as well, and Kamal is also doing flags. Sri Lakshmi, you're also doing flags. RC, you're also doing flags. Yeah. All of us are doing flags, and if you have flags, probably the decentration rates, everything will come down. But I don't think it's 37%. Are you sure?
Yes, sir. So I can share the data with you because I did one study for care group, and based on Tracy, we did some back issues with some different types of IOLs. And of course, I agree with you. If you add the total of flax, pure study group of flax, it's lesser.
No, with flax it's much less.
Much less,
Yeah.
but yes, I'm talking about a significant decentration. So 37% of patients are decentered, but they are not causing any problem. That's what I said. They're not
with
visible.
the
moment you
lenses,
cross
yeah.
0.65 and it's an aberrated lens, even if it's a negatively spherical aberrated lens, that is when things will start happening. The coma and the trefoils will start coming in. More so the
Absolutely.
comas.
I think both with the IHANS as well as I'm talking about monofocal plus lenses as well as with the EDOF lenses, the decentration can cause problems. Or yeah, of course, multifocal or any trifocal for that matter. I think we are on time. And for the next session as well.
Kamal, Kapur, sir, so regarding negative aspheric and positive aspheric, which one do you prefer?
Positive spherical lenses aberrated are practically not marketed anymore.
Yeah.
They are not made anymore. All of them majorly are negative.
No,
Just the cube
no,
which you go for.
no. What he is asking is that the central alone, there's a slight positive spherical aberration which is there in this high-ans lens as well as in the EDOF lenses. And that's why they are playing around with the spherical aberration there. But generally, positive spherical aberration is not the lens which